The next speaker is Dr. Jordan Smoller. He holds the MGH Trustees Endowed Chair in Psychiatric Neuroscience, Professor of Psychiatry at Harvard Medical School, and a professor in the Department of Epidemiology at the Harvard School of Public Health in Boston.
Thank you, John, and thanks to the organizers for including me today. This is a great series of talks. I've already learned quite a bit, and that was particularly cool, what we just heard. Is there an advancer on this, or no? It was, right?
It's all AI, Jordan.
Oh, yeah. I just have to think.
Yeah. Sensor in the closet that knows you on the
Okay, that's all right. Well, if somebody can advance the slide, or maybe it's here. Good. So the big green button, I can't miss it. Okay. So what I'm going to try to do is talk to you a little bit about this notion of precision psychiatry and what some of the things that we're thinking about in that realm, what it actually might mean, and some of the challenges. And I'm mindful and agree completely with Niall's sentiment that we have to avoid hype. And so I'm going to caveat many of these things, as you'll see, that they are directions that the field and in particular highlight some of the work that we've been doing are going, but this has not solved all the problems that we've been talking about today. But first, I will just reiterate, especially for those who don't think about this all the time, that psychiatric disorders, as currently defined, are incredibly common. Estimates that more than half of us at some point in our lives would meet criteria for a psychiatric disorder, and that they typically onset early in life, which means that people who are affected are living with many of these conditions for quite some time, and that's related to the fact that they are a leading cause of disability and morbidity and even mortality. So as you may know, people with serious mental illness have up to a 10 to 25 year shortened lifespan. That's just staggering when you think about it. And suicide, as I'll talk about a little bit more, is a leading cause of death, especially among young people. And we have treatments that are very helpful for many people, and sometimes they're life-saving, but they're not helpful enough for everybody. And the numbers that you're seeing here, or the data in those bubbles, are basically from some of the biggest either effectiveness studies or meta-analyses for a variety of psychiatric disorders, and you can see what the challenge is. And the fact is that almost all of our FDA-approved medications, John will maybe talk about exceptions, are based on mechanisms that were identified, decades ago. So there's this urgent need to do better. And that's where I would argue there's some hope in thinking through the lens of precision medicine. And precision medicine could be defined many different ways, but this is a definition that I think is as good as any, which was stated by the Precision Medicine Initiative Working Group, which is pretty simple. Precision medicine is an approach to disease treatment and prevention that seeks to maximize effectiveness by taking into account individual variability in genes, environment, and lifestyle. And the key thing, I think, in that statement is individual variability. That's the lever that we think about. What makes this sort of, real world is that we have tools, technologies, and particularly data now that we didn't have until relatively recently. And that includes genomics and other omics, transcriptomics, and many more. We have large-scale biobanks, large-scale real-world health data sources, and also, of course, digital and mobile health technologies, new technologies for phenotyping and for analyzing data. So that puts us in a slightly different place than we have been. And that's good because we have some major challenges in the field of psychiatry in almost every area. One being fundamental diagnosis. What even is a psychiatric disorder? How do you define it? What are the boundaries between disorders, if there are any, or between what people consider normal variation? How do we identify people at risk and enhance resilience? How do we know what's a reasonable strategy that's going to work for prevention or early intervention? How do we match patients to treatments ahead of time that are maybe most likely to work? And can we design new treatments based on what we know from data that would be more targeted, less maybe serendipitous than what we've had before? So I'm going to give you just a couple of snapshots of, as I said, directions, and I'll go through this relatively quickly because I want to just give you a flavor of the kind of thing I'm talking about. One of them has to do with diagnosis. And we know, for example, this is an area that we're very involved in, that is genetics, that disorders defined by the DSM is the Diagnostic and Statistical Manual of Mental Disorders that is almost ubiquitous in psychiatric practice, and it's essentially a manual that defines psychiatric disorders in a canonical way. And when defined by those criteria, you get conditions that have been shown to be heritable. That is, genetic variation influences risk of those conditions, both in twin studies where the heritability estimates, which can range from 0 to 1 or 100%, are pretty substantial. But even now with molecular genetic studies estimating from common single nucleotide polymorphisms, significant heritability. So we know genes are involved, and we've also seen a really pretty remarkable increase in statistically robust associations for a whole variety of disorders. And what you're seeing on this graph is a little bit of a timeline where prior to 2009, let's say, there was kind of nothing that everybody agreed, maybe ApoE alleles for Alzheimer's disease, for complex common neuropsychiatric disorders. And then with the advent of large consortia, pooling data, genome-wide technologies, that led to a taking off of findings, and it just keeps going. We've by no means approached saturation. And not only those kind of common variants, but rare variants that implicate specific genes, especially in neurodevelopmental disorders like autism or schizophrenia. But that's for the diagnoses. And I mentioned the DSM, and the DSM is not a thing that was delivered on tablets. It has its own history. It began in the 1950s with DSM-1, and the latest edition, the latest major edition was now 11 years ago, DSM-5. And what you're seeing there is the evolution of the diagnostic labels. So they have been increasing. There has been a growth in psychiatric diagnostic labels. And even if you just look at, say, 3 categories of disease, how psychiatry has handled sort of diagnostic nosology, as we would say, which is sort of the classification, you see this sort of dynamic, let's put it that way, and maybe unstable kind of thing. So at the bottom there, you're seeing a timeline from DSM-3 to 4, and we've got 3 categories of things: pervasive developmental disorders, which include things like autism or autism spectrum, mood disorders, anxiety disorders. So just 3 chapters essentially in the book. And as the timeline goes, you see disorders are dropping out and some are coming in. When you get to DSM-5, a very rare thing happens, which is that there is lumping rather than splitting. Usually we're carving it up more finely. Now the field said, well, autism spectrum disorder is the label we will use for what we used to think of as different things. And you see new categories that are picking up what used to be, say, in the anxiety disorders and so on. So this is a moving target, and that is part of the reason that precision is difficult, because the way these diagnostic criteria arise is that it's a consensus of experts based on the best available evidence, but then making some decisions about what symptoms, because it's really mostly or almost basically entirely based on patient self-report, clinician observation, not biological theories or etiology, because maybe prudently people said, we don't know enough to do that. So one of the things that is, I think, a very interesting window that we're getting from genomics is being able to say in a more data-driven way, what are the relationships among these disorders? And in the cross-disorder group of the Psychiatric Genomics Consortium, we've now been looking at this for quite some time with ever-increasing data sets. And I was reminding Niall that he was the editor handling the first of these papers, which sort of identified cross-disorder loci. And what we've seen is that if you put together genomic data from very large data sets across many disorders, you can actually extract latent genetic factors that underlie disorders that we think of as clinically very distinct. They might be childhood onset or later onset. And you can't really read this probably, but in the first major effort to do this, we found basically 4 latent genomic factors that instead of having 8 different disorders or 11 different disorders and a subsequent one, we find many of these disorders load onto, and they are highly genetically correlated. One of them we called compulsive disorders, which was OCD, obsessive compulsive disorder, Tourette syndrome, eating disorders, psychotic disorders, including bipolar disorder and schizophrenia, neurodevelopmental disorders, internalizing disorders. And the loci that affect these sort of pleiotropic relationships have somewhat distinctive patterns of gene expression early in development. And we are now beginning to sort of track down, again, remove the category constraints completely, or not completely, but to an extent, and say, what can we learn about the biology in a more data-driven way? And this field now has grown quite a bit. What you're looking at here is a heat map of genetic correlations, genetic relationships. And what we increasingly see are some basic fundamental dimensions, at least at the genetic level, that emerge from these genomic studies. And so, the question is, could we begin to rethink a little bit and track down some of the biology not constrained by the diagnoses, which maybe are less precise? Let me move on to the idea of risk stratification. We're not very good at knowing who's at risk for disorders prior to their onset, notwithstanding the last talk, which I think is a really exciting possibility. But we also, in precision psychiatry in our lab, have been very interested in leveraging artificial intelligence, machine learning with big data, and sort of using an approach that's familiar to all of us in terms of AI's use, which is that major industries are built on predicting human behavior by collecting massive amounts of data about human behavior and then training models and using those to predict, in those cases, what people would like to see in their feeds or in their Netflix menu, whatever you call that. But we can do that with healthcare and with real-world health problems. And one of the things that we have focused on a lot are the electronic health records. And electronic health records are a vast, passively growing repository of real-world health encounters at a massive scale. And so, for example, just at our Mass General Brigham system across the way, we have, our EHR has 6.5 million patients, 3.5 billion rows of data. And those data are usable. They come in 2 big buckets. One is what we call structured data. So these are the things that have like diagnostic codes or laboratories or prescriptions. And then the much larger corpus of narrative text. When a clinician is seeing a patient, they write a note, or somebody interprets an MRI or a chest X-ray. And through things like natural language processing, those can be converted into usable data as well. And so one of the ways we early on began to think this could be useful is to address a problem that is a major one, a major unsolved problem. That's the problem of suicide. And rates of suicide, at least in the United States, have increased by 35% in the last couple of decades. This past year was the highest ever recorded. Among young people, nearly 60% increase over around that time, and it is now the leading cause of death among young people. And it turns out clinicians, we know this from extensive reviews, are not very good at knowing who's at risk and therefore knowing with whom to intervene. But there is a key fact that is potentially useful, and that is most people who attempt or die by suicide are seen by a healthcare provider in the month leading up to the event. So we have this window potentially, or this period of vulnerability. Most people, though, don't disclose their suicidality, so simply asking people is not necessarily going to get you there. And so we early on began thinking, could we combine some of the data that are there on health histories and use some AI or ML kinds of models? And we actually originally trained a model in our health system with about 1.7 million patients. This was a model that, for those who care, was a naive Bayes classifier, which is a pretty uncomplicated but pretty interpretable and computationally efficient model. And it detected 45% of all attempts or deaths at 90% specificity about 2 to 3 years in advance. Then we wanted to know, could something like this work not just in our health system, but others? And so we went on to validate it in 5 other independent healthcare systems, and it performed just as well. We went on to do a detailed economic analysis to ask, how accurate would these things have to be for them to be cost effective in routine care? And the answer was, at the levels of accuracy that our models and now others have, they do meet that threshold. They would be cost effective. Then we said, let's look prospectively. Can we predict, not just retrospectively with the data that we have? And so with Matt Nock at Harvard University, we did a study in our emergency department, our psychiatric emergency department, with about 2,000 patients who came in, and the clinicians were asked to rate, what do you think is the likelihood that this patient will attempt suicide in the next month or the next 6 months? And then we used our models, and we used our model alone, and we also used a version of the model that incorporates a very brief point of care survey that asks a few questions. And the bottom line was, the clinicians, these are the, is there a pointer? Yeah. So this is that AUC that you heard about before. That's not that much better than chance. The model with the self-report did quite a bit better. By 6 months, it's approaching 0.8. But here's what I think is particularly notable, and that is the positive predictive value. So that's, given that the model thinks you're at high risk, what's the probability you actually go on to make a suicide attempt in the next month or 6 months? And the answer there was 40% in the next month and 60% by 6 months, which is pretty actionable kind of numbers. So we have also now gone on to build an app that is integrated into the electronic health record at the point of care so that clinicians can receive this information, incorporates any kind of data stream we want, including the self-report survey. And through our new Center for Suicide Research and Prevention, we are launching a 4,000-person RCT, randomized controlled trial, in which we're delivering this information in the emergency room to clinicians and testing, does it really make a difference? We'll also be collecting data on what happens to folks, what's the clinician's decision, which we can then use to train a precision treatment rule, which would say, given this constellation of risk or features, what's the best outcome? What's the best thing you could do for this patient? One question that comes up when people do electronic health record research is, isn't it kind of crappy data? Because it's billing data, or it's stuff people happen to write in the notes. And so we did something which I still think has not been done since, which is, because we knew we were going to get these questions, and this was in a study of bipolar disorder. And we said, okay, we will train an algorithm. We will then have the algorithm go to our healthcare system's data and identify people who the algorithm thinks have bipolar disorder. And then we'll have it identify people who it thinks don't have bipolar disorder. And then we'll also invite people who carry a diagnosis of either depression or schizophrenia, which are very difficult distinctions sometimes to make. And we will have blinded expert psychiatrists and psychologists do the gold standard 4-hour diagnostic interview, the SCID-4 at the time. And let's see how it does. So we rolled the dice. And the answer was it did amazingly well. So these are actually 3 different versions of our EHR model. Not that important, but the point is, no matter how we defined it, more than 80% of the time, if the model thought you had bipolar disorder, a clinician blinded doing the gold standard interview agreed you had bipolar disorder. And if it didn't think you had bipolar disorder, 100% of the time the clinician agreed on these blinded interviews. We then also, and by the way, if you know the data on inter-rater reliability of psychiatrists, this is arguably as good as it gets. It's not like it's going to be 100%. We also then genetically validated this phenotype by saying, okay, because we actually collected DNA, and we said, now let's look at the heritability and the genetic correlation of our sample, defined by EHR algorithms, to the standard big Psychiatric Genomics Consortium sample. And the answer was it was identically heritable, and, oops, well, yeah. Well, it was identically heritable, and the genetic correlation was, over 80%. So we were pretty happy with that. That allows us then, we have a phenotyping automated definition in a sense, to do lots of other things. And one of the things that we wanted to do was see, could we predict or detect or screen for the development of bipolar disorder or the detection of undiagnosed bipolar disorder in advance? And so we have a consortium that we built a couple of years ago called the PsychEmerge Consortium, which has multiple healthcare systems around the country with EHRs and genomic data from biobanks. And the average delay from onset of symptoms to getting the correct diagnosis for people with bipolar disorder can be 6 to 10 years. The longer it is untreated, the worse the outcome is likely to be, more recurrent mood episodes, more suicide attempts. So in this case, we got together 3 large-scale health systems. We trained models, a variety of models actually, to predict future, now this is retrospective, but we can take a moment from which we want to predict the future occurrence of bipolar disorder. And again, I don't want to get bogged down in all the details, but I'll say that each site trained its own model, internally validated it, and then ported it to the other sites to train, and everybody had their own approach, random forests, gradient boosting machines, and a ridge regression. The bottom line was that the performance, and we also did what's called an ensemble machine learning, and that's what you're seeing in this table. The performance was similar to the same range for all of these models. And the people who were at very high risk had about a 19-fold, or well, really more like a 15 to 19-fold increased risk of developing or being diagnosed with bipolar disorder. We've also recently done this in our own healthcare system, but focusing on young people. And again, training models to look at how well we can capture the onset of bipolar disorder in youth or early onset bipolar disorder. And again, the models do pretty well. One thing to notice, though, is the positive predictive values here are low, right? I don't know if you can see this, but 2% to 4%. That means that if the model thinks you're at high risk, the probability, in this case, I think it was a window of 2 years, the probability that you would then develop bipolar disorder in the next 2 years was only a few percent, which turns out to be a lot higher than if we didn't know anything about you. So these are not diagnostic algorithms or anything. They would be, like with the suicide thing, a way of alerting attention or drawing attention to the need for further evaluation so that people are not slipping through the cracks. Okay, how about identifying biomarkers and risk of disorder, again, using individual differences. And again, I mentioned the PsychEmerge Consortium, which has really grown to be a phenomenal collaboration now among many sites around the country. And we have electronic health record data now for about 29 million patients with about 2 million genomes. And we're doing a whole variety of things. One of them has been to look at the value of what we call polygenic risk scores. People here probably know that if you do a genome-wide association study of, say, bipolar disorder or schizophrenia, with enough samples, you'll find variants that are statistically strongly associated. Their individual effects are tiny. These are common variants that, barely nudge your risk. But if you add them up into a single score, you get something more influential. And it's a pretty simple score, meaning literally an addition weighting the effect sizes of their association by the number of alleles a given person has at that variant, and then just summing that score. And in the realm of schizophrenia, where this has been looked at quite a lot, the scores, depending on how you look at the data, are very promising or very unpromising, I guess. So these are data summarizing what's gone on from the last large-scale genome-wide studies of schizophrenia. If you take people who are in the top 10% of that distribution of polygenic risk scores and look at their risk, say, of schizophrenia compared to people at the bottom end, it's substantially higher. It's like 15, 16-fold. If you look at people in the top percent versus everybody else, it's still pretty significant. It's about 5.5-fold. But you can see in that panel C that these are not distributions that are segregating. They're not, it's not, I mean, it is bimodal, but the means are very close. And one of the things we wanted to know, again, a lot of the research that we're interested in is focused on, let's think about implementation. Let's think about ways to use data in the relatively nearer term to do something that matters. And the question was, do these kinds of effects appear in real-world health data if you just implemented these scores? And so again, through this PsychEmerge consortium, we did this, and I'll just summarize it to say that we found very strong statistical evidence of association of a polygenic risk score for schizophrenia with schizophrenia across 4 health systems. The effect sizes were smaller than what's been reported in the rarefied research cohorts. The other thing, though, that you can do in a health system is you actually have health data on everything, not just the disorder you're interested in that you may have collected the data for. And so now we can do something about, to ask the question, what are these genetic risks for, say, schizophrenia also associated with across the phenome, as we would say? And what you're seeing here is, this is a Manhattan plot, for those who know what that is, on its end in the shape of a body, because these are all the different systems in the body. And each of these is a diagnostic entity. And the things above the dotted line are associated with the polygenic risk for schizophrenia in our health system. Many of them are other psychiatric conditions, which makes sense. We've already said there's a lot of genetic overlap there. Some of them are interesting and not as obvious, like inflammations of joints, hepatitis C, obesity and diabetes, and so on. So there's interesting things one can learn there. We also have been interested in, could we leverage another part of the data that people don't usually look at, which is the lab values. If you think about it, there's millions of data points on labs that have been drawn on people. They're often drawn on people who you suspect an illness of, so they're not just random labs. But what we did here was ask the question, if you took a polygenic score for depression, is there anything in all of the labs that a health system collects that would be statistically or meaningfully associated? And we did this across, again, multiple healthcare systems. And the answer was, there was one thing that was screamingly positive statistically, and almost exactly the same effect size across all the healthcare systems. And that thing was white blood cell count, which is interesting. It's also hard to interpret because white blood cell count is not a thing you measure for depression, let's say. And in fact, the magnitude of the elevation of white blood cell count was not like an infection. But it was pointing to something going on in that particular domain of our biology. And we actually did look at the differential. People may know that when you get a white count, you get a differential of monocytes and neutrophils and lymphocytes. It didn't, either we didn't have the power or it didn't segregate. We didn't really see anything there. But it's consistent with some of the inflammatory, ideas about how depression happens. This needs a lot of, again, let's not overhype, but it's an illustration of how you can kind of extract information from some of these data. And then I think there are many challenges with risk stratification, which is why maybe it hasn't hit care as much. One of the great things is that we've seen is that these EHR-based models, but this is true for other things probably, can outperform clinicians. That's great. However, they have their own challenges. Like when you have algorithms that are based on real-world healthcare data, that means you're training it on what happens in the real world. And sometimes what happens in the real world is not good. And that can build or bake biases into the models themselves. Sometimes there's difficulty in porting these models. It's not like I train a model here and it always works somewhere else. How am I supposed to tell clinicians, take this information and combine it with your clinical judgment? Am I saying that it supersedes your clinical judgment? No. But how do you weigh it? Polygenic risk scores are maybe arguably the best established biomarker in psychiatry, in the sense that they're clearly statistically very associated with a whole variety of things. But they are relatively small effect sizes. Almost all the training data for them has been based on people with European ancestry predominantly, so their generalizability and equitability is pretty questionable. Again, how do you best combine them? And then ultimately, we can do lots of modeling and find interesting things, but it only matters, I think this is John's point this morning, it matters if you can do something clinically, if it actually gets somewhere. And there are a lot of, we found this now as we are trying to implement some of these things in, for example, suicide prevention, there's a lot, that last mile of implementation is not trivial, but it's crucially important. And it's not something that we often think about, but we have to think about more, I think. Treatment matching, I'll try to go somewhat quickly here, but I've already said, I am a practicing clinician as well, and if somebody comes to me and I decide that it would probably, or that we decide together that it would be good for them to try an antidepressant, or they want to try an antidepressant, what should we go with? I don't know. It's trial and error. We don't really have a way of knowing ahead of time. If you look at, for example, antidepressant trials, and you put them together, the difference between drug effect and placebo is less than 2 points on the Hamilton D depression scale, which is a conventionally used depression scale. That's terrible. It's not clinically meaningful. But that's also not the whole story. And people here know this either from personal experience or your clinicians or whatever. Somebody might do superbly well and another person really has no benefit. And it turns out if you model the data, there are subgroups of people who do well and others who don't do well. One way people have tried to address this is using genetics, and pharmacogenetics that's actually out there in clinical practice now. And the way people have implemented it is to look at what we call either pharmacokinetic related genes, that is genes like the P450 enzymes in your liver that are involved in metabolizing antidepressants, and pharmacodynamic genes, which are in theory the genes that make the targets of the drug action at a biological level. Usually we don't know that. This is out there, and in fact the FDA has labeling for many drugs. Almost all of it in the realm of psychiatry is based on those P450 enzymes. And not only that, but these are commercially available, and I'm sometimes shocked at how many people are actually using them. So what happens is you send away for the test, they run the DNA through their proprietary algorithm, they give you the result, and they give you often like a traffic light thing. This drug is fine, this drug is maybe worry about, and this is like terrible red light. The studies, if you put them together, do show some effect of this. The way this is done usually is you give the results to the clinician. or you just let people go treatment as usual. But the effects are not huge. And there are all kinds of challenges with interpreting the data, and that is undoubtedly why the ISPG, which is our International Society for Psychiatric Genetics, the American Academy of Child and Adolescent Psychiatry, the American Psychiatric Association, basically are all saying, no, the evidence is not good enough to be useful clinically. And, you know, I think I've mentioned some of the limitations here, but, you know, these studies which look at testing versus treatment as usual are basically saying, are you more likely to respond or not? But I actually want to know, what are you more likely to respond to as a clinician? Mostly they don't include a lot of other factors that could bias the results or confound the results. And these algorithms are proprietary, so I don't know how they're using them. I can tell you that the pharmacodynamic variants that they put in those tests are probably not contributing anything because they're not really real pharmacodynamic variants. And, you know, other problems with it. So that hasn't solved the problem. There are some other approaches people have taken. This is work from Amit Etkin and others. One of the first of the studies that they've reported from large treatment studies looking at EEG signatures, resting state EEG, and finding evidence that it's predicting sertraline, which is SSRI, versus placebo response. And maybe more importantly, that that signature was inversely related to response to transcranial magnetic stimulation, which is another treatment we have usually for treatment-resistant depression. And so that work is proceeding. We have, again, gone back to the vast amount of data and the opportunities potentially from AI. And this is a work that was led by Ihan Shu, who you see here. We took data for all patients started on an antidepressant of 4 different classes. These are the 4 first-line classes: SSRIs, SNRIs, bupropion, and mirtazapine. And we trained models, essentially, to look at predicting response to treatment. And this is what, as I said, I see as a clinician now. If you tell, I have these 4 options. I have 2 patients, Tom, Megan. On average, there's about a 50-50 chance that they'll respond to any of these, and I don't know which one will turn out to be right. The models, which we trained a lot of models, well, 10 or 14 or something like that, they all did pretty well. The results I'm showing you are from a deep neural network model, but it wasn't substantially different from some of the simpler models. And it predicted response with pretty good accuracy, or actually positive predictive value, this is. And these are 2, you know, those 2 patients these are actual data from 2 patients. So Tom is predicted to respond to an SSRI very well, Megan not so well. And that would be good. If I started with an SSRI, I'd like to know that, you know, what the answer to this question is for a given patient. But the more important question is, so what are they more likely to respond to? And using sort of counterfactual modeling, we can estimate the likelihood of response to any of these 4. Now, it turns out that Tom was going to do pretty well regardless, so I'm not worried about him. Megan was not going to do all that well, although the most likely to benefit her was mirtazapine, which is not a medicine we use first line typically. But this is a principle that I think can be expanded to other treatment options and may be of value. Prevention, we heard, is vastly understudied. And in the interests of time, I'm not going to go into great detail here, but if you think about what can you tell people to do to prevent the onset of depression? Maybe don't have affected relatives. Maybe don't have a difficult childhood, because those are really strong risk factors. And don't use drugs. But you know, that's not terribly actionable. So we've been doing, this is work led by Carmel Choi, a whole series of large-scale studies looking at leveraging genomic data, EHRs, the UK Biobank, which has repeated measures of incident depression. And the bottom line was that there were 2 factors that in a lot of different cohorts that we've seen now are not only strongly associated with the reduced risk of depression in a prospective way, but through techniques like Mendelian randomization, which is a method of getting at the likelihood of a causal impact, appear to be causally related. And the good news is that they seem to be effective, maybe not to quite the same extent, regardless of your polygenic risk for depression or your history of exposure to trauma. And those two things are, anybody want to guess? Sleep and exercise. Ooh, good one. Sleep wasn't one of them. Yes, so we've found physical activity and social connection over and over. Even when you look, for example, in the UK Biobank, we looked at 105 different potentially modifiable things. It turned out that daytime napping was a negative predictor. That was an apparent risk factor. So that could go either way, I guess. There's some evidence that there might be differential prevention sensitivity based on individual differences. This is a study suggesting that polygenic risk for depression interacted with social support in predicting risk for depression. But again, these kinds of data-driven insights, I think, can be useful. And the last thing is genome-guided precision therapeutics. And this has been a success in other areas. For example, in cancer, as we know, the last decade has been about identifying driver mutations and other genetic lesions, usually somatic, that can be targeted with targeted therapies. In rare disease like cystic fibrosis, same, really transformative changes in the outlook for patients based on understanding the genetic mechanism. And just this last week or so, a follow-up to some work that had been done previously, some of it led by folks at the Broad here, showed again that if you have genetic support for a drug target or a drug mechanism, that confers a more than 2.5-fold increased probability that you will get to drug launch. And that was independent of the effect size or the allele frequency, meaning even these little things that we think, oh, who cares that it's nudging the risk a little bit, are presumably pointing to potentially valuable biology. And I'll just give you one example where, just because Robbie Mueller, who did this work in our lab and also at the Broad, looked at variants associated with schizophrenia. One of probably the most common, it is the most common missense variant that shows up as very strongly associated is a missense exonic change in a gene called SLC39A8, which is a manganese transporter. And that's of note because manganese is a cofactor for many enzymes that are involved in glycosylation, the addition of sugar moieties to proteins or lipids. And glycosylation turns out to be a very fundamental pathway involved in brain maturation, brain development, and a whole variety of other things. And through a series of studies, which again, I'm not going to detail, Robbie showed, using data from our biobank and profiling patients who carried the schizophrenia risk variant, but didn't necessarily themselves have schizophrenia, that there is a measurable decrease in serum manganese among these folks, that if you profile their cells, the complexity of glycosylation on their proteins is much more limited. And if you knock this variant, the human variant, into a mouse, you see dysregulation of protein glycosylation in a somewhat region-specific way. And so this is an example, there are others, of course, of how genetic studies can point us to novel hypotheses, novel biology. This is an interesting one because Robbie has also shown that among those people who have a very rare congenital disorder of glycosylation, where they have a loss of function in this gene, it's knocked out, they have these deficits in glycosylation, but if you give them manganese and you supplement them basically, you can partially at least reverse that biochemical deficit. And manganese is a pretty safe and widely available thing. And so, who knows, but could this be, and Robbie's following this up now in much more extensive mouse studies, could this be an element of a treatment to supplement response in schizophrenia. A lot more to be done to say that's the case. But that's just one example of some of the biological or mechanistic themes that are emerging from genomic studies. And many of these now are turning into potentially viable avenues for drug development, and companies are pursuing them. The last way you can get some information here is, remember I told you we had done these large-scale studies looking at the underlying genomic structure. Then if you take those variants and look at and essentially impute the transcriptome and look at the genes that are implicated by variants underlying these factors, you can then match those genes to drug mechanisms of action and implicate potential drugs that are already out there, or compounds that are out there, to be repurposed for what might be transdiagnostic effects in this case. So here we identified 466 genes that map to these factors via their transcriptomic profiles, and that allowed us to identify nearly 40 potentially repurposable drugs. So again, another potential avenue. So bottom line, I think I'm over, is this is early still in the story, but I think this lens of leveraging the data we have, focusing on individual differences, and importantly, thinking about what we call innovation to implementation. So the things that I'm particularly interested in or excited about are things where I can see the path, not in 40 years. That doesn't mean the basic research isn't crucial, but I'm seeing patients every week. And this is there are things we could potentially drive to see whether we could make use of them now. So I think I'm going to stop there.